Hello and welcome to my presentation. My names are Peter Elyanu and I work with the Baylor College of Medicine Children's Foundation in Uganda. And I will be presenting on the rapid ART initiation and the risk of mortality and loss to follow-up in children with HIV in Eastern and Southern Africa. And this was a retrospective cohort study. In 2017, the WHO recommended ART initiation within 7 days of diagnosis and upon clinical assessment in adults and children. This recommendation was based on retention and viral suppression and survival benefits reported in adults. However, data of these benefits in children are scarce. So we examined the association between rapid ART initiation and 24-month all-cause mortality and loss to follow-up in children. So this was a retrospective cohort study of children with HIV who initiated ART at 7 Baylor International Pediatric AIDS Initiative Centers of Excellence in 6 countries. And this was in Uganda, Tanzania, Malawi, Botswana, Lesotho, and Eswatini. So we included children who were under 15 years of age and had initiated ART with at least 3 ARVs and initiated treatment between 2014 and 2017. We excluded children who experienced ART experience at entry into care, except for those who had exposure only to PMTCT regimens. So we defined our exposure was rapid ART initiation, which we defined as same-day initiation or initiation within 2 to 7 days. And our reference group was children who initiated ART after 1 week. And the outcome in our study was all-cause mortality and loss to follow-up. We defined loss to follow-up as being 90 days or more late for the last clinic appointment. And follow-up time accrued from ART initiation date to the earliest of loss to follow-up, death, transfer out, 24-month follow-up, or database closure date, which was 31st December 2017. And we considered death and loss to follow-up as competing events. So we assessed the association between rapid ART initiation and mortality or loss to follow-up using sub-distributional hazard regression for competing risks, and we adjusted for the known risk factors for mortality and loss to follow-up. And we imputed missing data using multiple imputation by chained equations. So our results. In the study period, about 5,900 children were enrolled in care in the clinic, and about 5,400 of them initiated ART. So we excluded those who initiated ART after 90 days and those who were not naive and those who were above 15 years. So we included a total of 3,299 children in this study, and about 24% of them initiated ART on the same day. 50% of these children were girls and 40% were aged under 2 years. And the total follow-up time was about 57,000 person months, and about 7.7% of them died and 9.3% were lost to follow-up. On regression analysis, we found that there was no difference in mortality between children who initiated ART within 7 days of diagnosis as compared to those who initiated ART after 7 days. However, loss to follow-up was higher in children who initiated ART within 7 days as compared to those who initiated after. So children who initiated ART within 7 days were 1.8 times more likely to be lost to follow-up as compared to children who initiated ART after. And this was after adjusting for the age, the CD4, the WHO clinical staging, the period of ART initiation, as well as the country income levels. So we found that rapid ART initiation in children is associated with an increased risk of loss to follow-up, but not mortality. The reasons why children who initiate ART within the 7 days dropout of care are not well understood. However, plausible reasons could include caregivers are not ready, but they accept to start because ART has been offered, or because they feel pressured to start ART and they drop out of care thereafter. The lack of readiness to start and feeling pressured by providers to start ART on the same day has been reported as a reason for dropping off care, even among adults. Our study had limitations. One is that children who are lost to follow-up may have died and were classified as lost to follow-up. Therefore, these findings may underestimate mortality. However, we are not certain if this bias would be differential or non-differential. And in our analysis of loss to follow-up, we did not control for structural and psychosocial determinants of loss to follow-up, like the distance traveled to the clinic. And hence, there is a potential for residual confounding. However, notwithstanding the limitations, findings from our study, which is conducted in a programmatic setting, has important implications for the implementation of universal ART and rapid ART initiation guidelines in children. These findings suggest that in programmatic settings, it's feasible to implement ART in children. However, loss to follow-up needs to be addressed. To attain better outcomes of children during implementation of rapid ART initiation, ART protocols that incorporate readiness assessment and retention strategies should be developed during for implementation. And in addition, since HIV progression in untreated children is fast and mortality is high, care should be taken not to over-delay ART and miss on the benefits of antiretroviral therapy. Thank you so much.